Picture this, a sterile operating room, bright lights reflecting off metal instruments, and the steady beep of monitors suddenly turning into chaos. A renowned surgeon throws his gloves down and declares the case lost. Everyone leaves. Everyone except one nurse who stayed behind and did something so controversial, so against every rule, that it nearly ended her career. But it also saved a life. What would you have done in her place? Stay with me, because this story will challenge everything you think you know about following orders. Now, my name is Helena Grant, and I never imagined that one Thursday night would define my entire nursing career. I grew up in Cedar Rapids, Iowa, where everyone knew everyone, and the local hospital had exactly 12 beds. It was the kind of place where nurses doubled as receptionists and sometimes even janitors. But I always dreamed bigger. After my father died from complications during a routine surgery when I was 16, something inside me shifted. I needed to understand medicine, to be in those rooms where life and death decisions were made. So I moved to Chicago, worked 3 jobs to pay for nursing school, and eventually landed a position at Metropolitan General Hospital, one of the busiest trauma centers in the Midwest. The building itself was imposing, all glass and steel, rising 15 stories above the south side. Inside, the emergency department never slept. Ambulance sirens, overhead pages, the smell of antiseptic mixed with coffee from the nurses' station. I had been working night shifts in the surgical unit for 3 years. That particular night started like any other. I arrived at 6:45 in the evening, checked in with the day shift nurse, reviewed patient charts, and prepared my medication cart. The surgical floor was quieter than usual. 2 post-operative patients recovering from gallbladder removals, 1 hernia repair, and 3 empty beds waiting. I remember looking out the window at the Chicago skyline, lights beginning to twinkle as dusk settled over the city. The air conditioning hummed steadily, and I felt that familiar sense of calm before a storm. Little did I know that in less than 2 hours, I would be standing alone in an operating room, making a choice that would haunt and define me forever. Now, I want to know something from you. Where are you watching this from? Drop a comment below and tell me your city, your country. And if this story has already grabbed your attention, if you can feel the weight of what's coming, hit that subscribe button right now. Because what happens next, what I did in that operating room, it's going to shock you in ways you cannot imagine. At 8:37 in the evening, everything changed. The overhead speaker crackled to life with a trauma alert. Motor vehicle accident, multiple casualties incoming, estimated arrival in 4 minutes. I rushed down to the emergency department with 2 other nurses. The automatic doors burst open, and paramedics wheeled in a man on a stretcher, his clothes soaked in blood. He was approximately 40 years old, unresponsive, with visible trauma to his chest and abdomen. The paramedic rattled off his vitals as they transferred him to the trauma bay. Blood pressure 70/40 and dropping. Heart rate 130. Respiratory rate shallow and labored. Dr. Mitchell Brennan, our chief trauma surgeon, immediately took control. Dr. Brennan was a legend at Metropolitan General, a tall man in his late 50s with silver hair and hands that never trembled, even in the worst cases. He had performed over 10,000 surgeries in his career. That night, he barely glanced at the patient before ordering him prepped for emergency surgery. Massive internal bleeding, he announced, possibly ruptured spleen and liver damage. We moved fast. Within 12 minutes, the patient was in operating room 3. I was assigned as the circulating nurse, responsible for managing the sterile field, passing instruments, and monitoring the patient's condition. The anesthesiologist, Dr. Sandra Park, worked quickly to intubate and stabilize him enough for surgery. The room was ice cold, as all operating rooms are, maintained at exactly 68 degrees to prevent bacterial growth. I remember the hum of the ventilator, the glow of the monitors, and that peculiar smell of iodine and blood that you never quite get used to. Dr. Brennan made the first incision at 9:03. What he found inside made him pause. The damage was catastrophic. The spleen was shattered. The liver had a deep laceration, and there was blood everywhere, pooling faster than we could suction it. But there was something else, something in Dr. Brennan's expression that I had never seen before. It was doubt. Thank you for staying with me through this part. I know it is intense, but I need you to understand the gravity of what was happening in that room. If you are feeling what I felt that night, that mix of fear and determination, then go ahead and subscribe now. Hit that notification bell too, because this story takes a turn that no one expected, including me. What happens in the next part changes everything. And for the next 47 minutes, Dr. Brennan fought to save this man's life. He worked methodically, clamping vessels, cauterizing bleeders, and repairing what he could, but the bleeding would not stop. Every time he controlled one source, another would open up. The patient's blood pressure continued dropping despite multiple transfusions. I watched the monitors obsessively. 70/35, 60/30, 50/28. His heart rate became erratic, jumping between 140 and 160 beats per minute. Dr. Park kept calling out numbers, adjusting medications, pushing more blood products. The scrub nurse, an experienced woman named Janet, who had worked with Dr. Brennan for 15 years, handed him instruments with mechanical precision, but I could see the sweat forming on Dr. Brennan's forehead, could hear the slight change in his breathing. The patient's abdomen was open, and inside it looked like a war zone. Blood obscured our view constantly despite continuous suctioning. Dr. Brennan discovered the source of the unstoppable bleeding, a tear in the inferior vena cava, the large vein that carries blood from the lower body back to the heart. This was the nightmare scenario. The tear was in a location that was nearly impossible to repair, tucked deep behind other organs. To reach it properly would require moving everything out of the way, but the patient was too unstable to survive that kind of manipulation. It was a cruel paradox. We needed to fix the bleeding to stabilize him, but we could not reach the bleeding without destabilizing him further. Dr. Brennan tried anyway. He attempted to place a clamp, but his hands, usually so steady, were working in a pool of blood that refilled every second. The anesthesiologist's voice grew more urgent. Blood pressure 40/20, heart rate 180, oxygen saturation dropping. We are losing him. Dr. Brennan tried another approach, then another. Nothing worked. The clock on the wall read 9:51. Where are you watching this from right now? I want to know because this story, this moment, it transcends borders and languages. Medical professionals everywhere understand this horror, and maybe you do too, even if you have never set foot in a hospital. Drop your location in the comments, and if you are still with me, please subscribe. You need to see how this ends. At 9:54 in the evening, Dr. Mitchell Brennan stepped back from the operating table. His shoulders sagged, and he pulled his surgical mask down. "Everyone, out," he said quietly. There was no anger in his voice, just exhaustion and defeat. The room went silent except for the alarms on the monitors. Janet, the scrub nurse, looked at him in disbelief. "Dr. Brennan," she started, but he cut her off. I said out, "This patient cannot be saved. The tear is inaccessible. He has lost too much blood, and his body is shutting down. Continuing is pointless. Document the time and cause of death as massive hemorrhage from motor vehicle trauma. Everyone out now." Dr. Park began shutting down the anesthesia equipment, her face expressionless, but her hands shaking slightly. Janet carefully placed her instruments on the tray. The surgical resident who had been assisting looked shell-shocked, but followed Dr. Brennan toward the door. I stood frozen by the instrument table. My eyes went to the monitor. Heart rate was now 210, irregular and chaotic. Blood pressure barely registered, but he was still alive. The heart was still beating, even if barely. I looked at the patient's face, pale and lifeless, but not yet gone. Something inside me refused to move. Dr. Brennan paused at the door and looked back at me. "Nurse Grant, that includes you. Please turn off the monitors and clean up. I will handle the paperwork." Then he left. They all left. Within 30 seconds, I was alone in operating room 3 with a dying man on the table, his abdomen still open, blood still seeping into the surgical field. The lights were too bright. The silence was deafening except for the erratic beeping of the heart monitor. I should have followed orders. Every protocol, every rule, every ounce of training told me to walk out that door, but I could not. I stared at that monitor, at that dying heart still fighting, and I remembered something from 8 years ago. I need to take you back to understand why I could not leave that room. It was 2015, and I was still in Cedar Rapids, working as a nurse's aide at Mercy Medical Center while saving money for nursing school. One night, a logging accident brought in a worker with similar injuries, catastrophic bleeding, damaged organs, and a tear in a major blood vessel. The surgeon on duty, Dr. Raymond Torres, was a 72-year-old man who should have retired years ago, but loved medicine too much to quit. Everyone said he was from the old school, trained in Vietnam field hospitals where supplies were limited, and improvisation was survival. I watched him that night. When the bleeding would not stop and the other doctors looked defeated, Dr. Torres did something I had never seen before. He used a technique he called compression tamponade, a method that involved packing the bleeding area with surgical sponges in a specific pattern, creating pressure from multiple angles to collapse the vessel temporarily, while allowing time to access the tear properly. It was crude, it was risky, and it was not in any modern surgical textbook, but it worked. The patient lived. I never forgot that technique. I asked Dr. Torres about it weeks later, and he spent an hour teaching me the principles, pressure points, angles, the amount of force needed, how to pack the sponges so they compressed without causing additional damage. He made me promise something. If you ever see someone dying from bleeding that seems unstoppable, and all the experts have given up, you try this. You try because doing nothing is not medicine. It is surrender. Dr. Torres died 6 months later from a heart attack. but his words never left me. Now, standing in operating room 3, alone with a man whose heart was about to stop, I heard Dr. Torres's voice in my head. I looked at my hands, then at the surgical field, then at the monitors. The heart rate was becoming more erratic, diving into the 200s, then suddenly dropping to 100, then spiking again. This was it. In maybe 60 seconds, his heart would stop completely. I made my decision. I grabbed a fresh pair of gloves from the supply cart, pulled them on, and stepped up to the operating table. My hands were shaking, but my mind was clear. I worked faster than I ever had in my life. First, I grabbed the suction device and cleared as much blood as I could from the surgical field. The inferior vena cava tear was there, just as Dr. Brennan had said, tucked in an impossible position behind the liver and beneath the right kidney. Blood pulsed out with each heartbeat, dark red and relentless. I took 6 surgical sponges from the instrument tray, the large ones we call lap sponges, and I began Dr. Torres's technique. The first sponge went directly above the tear, pressed firmly against the vessel wall at a 45-degree angle. The second went below, creating a sandwich effect. Then I packed 2 more on either side, creating a box of pressure around the area. My hands moved automatically, muscle memory from that night 8 years ago when Dr. Torres had demonstrated this on a model. The key was pressure without crushing, compression without tearing. I added 2 more sponges, deeper this time, using a long instrument to place them behind the injured area. The entire maneuver took 90 seconds. Then I waited, my hands still inside the patient's abdomen, holding the final sponge in place. I watched the surgical field. The blood flow slowed, not stopped, but slowed. I checked the monitor. Heart rate was dropping. Now 190, still critical but no longer spiraling. I maintained pressure, counting seconds in my head. 30 seconds, 60 seconds. The bleeding slowed further. At the 90-second mark, I carefully removed one hand and used it to adjust the overhead light for a better view. The compression was working. The sponges were creating enough pressure to temporarily collapse the vein around the tear, giving the vessel walls a chance to react. I knew this was not a permanent fix. The sponges would have to come out eventually, and when they did, the bleeding could restart. But it bought time. Most importantly, it stabilized the patient enough that the tear might become accessible. I quickly assessed the situation. With the bleeding controlled, I could see the anatomy more clearly. If someone helped me, if we could retract the liver and kidney properly with the bleeding stopped, we might actually reach that tear and repair it. But I could not do that alone. I needed the surgical team back. I reached for the emergency call button with my free hand and pressed it 3 times, the code for immediate assistance needed in the operating room. Within 20 seconds, I heard running footsteps. The OR door burst open, and Janet, the scrub nurse, appeared. Her eyes went wide when she saw me standing at the table, my hands inside the patient, surrounded by bloodied surgical instruments. "Nurse Grant, what are you doing?" she whispered, her voice a mix of shock and something else, maybe awe. "I need Dr. Brennan back in here right now," I said, my voice steadier than I felt. "The bleeding is controlled." Janet stared at me for 3 full seconds, then spun and ran. I heard her shouting in the hallway, "Dr. Brennan, get back here. The patient is stabilizing." Within a minute, Dr. Brennan rushed back into the room, still in his surgical gown but with his mask pulled down. His face went from confusion to shock when he saw me at the table. "What in God's name?" he started, then stopped. His eyes went to the monitor. Heart rate was now 160 and steady. Blood pressure had crept up to 55/30. Not good, but no longer terminal. He approached the table and looked into the surgical field. "How?" he asked simply. I explained quickly. "Compression tamponade, multiple sponges creating pressure from different angles, temporarily collapsing the vessel to stop the bleed. With it controlled, the tear is now accessible if we retract properly." Dr. Brennan said nothing for a long moment. His face was unreadable. Then he turned to Janet. "Get Dr. Park back in here. Get the resident. Scrub back in now." He looked at me. "Nurse Grant, maintain exactly what you are doing. Do not move those sponges until I say so." The team reassembled in minutes. Dr. Park restarted the anesthesia, adjusting medications to support the patient's fragile cardiovascular system. The resident returned, looking confused but ready. Janet handed Dr. Brennan fresh instruments. And then, with me holding the compression in place, Dr. Brennan went back to work. This time, with the bleeding controlled, he could see. He carefully retracted the liver and kidney, creating space. He could reach the tear now. Over the next 35 minutes, Dr. Brennan performed what he later called one of the most technically difficult repairs of his career. He sutured the vena cava tear with tiny, precise stitches, reinforcing the vessel wall with a synthetic patch. Only when the repair was complete did I, under his instruction, slowly remove the sponges one by one. We held our breath. The repair held. No bleeding. The heart rate began to drop, stabilizing at 120. Blood pressure started climbing, 60/35, then 70/40. Color started returning to the patient's skin. At 11:40 10:47 in the evening, Dr. Brennan closed the abdomen. The patient was alive. The moment we wheeled the patient out to the intensive care unit, Dr. Brennan pulled me aside into an empty consultation room. His face was hard, unreadable. "Nurse Grant, what you did in there was completely unauthorized. You performed a medical procedure without physician supervision. You ignored a direct order to leave the operating room. Do you understand the severity of this?" I understood. I also understood that a man was alive who should be dead, but I said nothing, just stood there in my blood-splattered scrubs, suddenly feeling the weight of the last 3 hours. Dr. Brennan continued, "I am required to report this to the hospital administration. You will be suspended pending a full investigation. You are to leave the surgical floor immediately and not return until cleared." I nodded. He opened the door, and I walked out. Within an hour, I was in the office of Margaret Holloway, the hospital's chief nursing officer. She was a stern woman in her 60s, known for running the nursing staff with strict adherence to protocol. "Nurse Grant," she said without preamble, "you have put this entire hospital at risk. What if that patient had died while you were alone with him? What if you had caused additional damage? You are not a surgeon. You had no authority to perform any procedure." I tried to explain, but she held up her hand. "You are suspended without pay, effective immediately. Security will escort you out. Do not discuss this case with anyone. An investigative committee will be convened, and you will be notified of the hearing date." The next 2 weeks were the worst of my life. I sat in my small apartment in Lincoln Park, staring at the walls, replaying that night over and over. Did I make the right choice? I saved a life, but I violated every rule. Nurses started texting me, some supportive, others angry. I heard through the grapevine that Dr. Brennan was also under investigation for abandoning a patient. The medical community was divided. Some called me a hero. Others called me reckless and dangerous. The local news picked up the story. Hospital nurse defies orders to save patient life. My name was everywhere. I could not leave my apartment without someone recognizing me. The attention was suffocating. On the 16th day of my suspension, I received a call from an unknown number. I almost did not answer, but something made me pick up. "This is Thomas Garrett," a voice said. "The man whose life you saved. I want to meet you." We met at a small coffee shop near the hospital. Thomas Garrett was a 42-year-old high school teacher from Naperville, married with 2 daughters aged 10 and 13. He had been driving home from a parent-teacher conference when a drunk driver ran a red light and hit him broadside. He remembered nothing from the accident until waking up in the ICU 5 days later. "The doctors told me I should not be alive," he said, his voice thick with emotion. "They said my injuries were unsurvivable, but then they told me about you, about what you did when everyone else had given up." His eyes filled with tears. "My daughters still have a father because you refused to walk away. How do I even begin to thank you for that?" I did not know what to say. I just did what I thought was right. I finally managed. He reached across the table and took my hand. "You gave me my life back. Whatever happens with your job, with the investigation, I want you to know that." 2 days later, the hospital convened the disciplinary hearing. It was held in a large conference room with 12 people present: administrators, senior physicians, nursing leadership, and legal counsel. I sat alone at one end of the table while they reviewed the case. Dr. Brennan testified first. He explained the medical situation, confirmed that he had ordered the room cleared, and acknowledged that standard protocol supported his decision at that time. But then he said something unexpected. "In my 32 years as a surgeon, I have seen maybe 6 cases like this. 5 of those patients died. Nurse Grant used a technique I had never encountered, a technique that should not have worked but did. She made a decision under extraordinary circumstances, and because of that decision, a man lived. I do not condone violating the chain of command, but I also cannot condemn someone for refusing to let a patient die when there was even the smallest chance." Then they brought in Dr. Raymond Torres's records from Cedar Rapids. They contacted Mercy Medical Center and obtained documentation of the case from 2015, complete with Dr. Torres's detailed notes on the compression tamponade technique. A surgical expert reviewed the method and confirmed it was legitimate, though rarely used and not widely taught. Finally, Thomas Garrett was allowed to speak. He stood before the committee and told them about his daughters, about his life, about what it meant to still be here. Then he said, "If you punish Nurse Grant for saving my life, you are telling every nurse in this hospital that following orders is more important than saving lives. Is that really the message you want to send?" The committee deliberated for 6 hours. At 7:35 in the evening, Margaret Holloway called me back into the conference room. The committee had reached their decision. "Nurse Grant," she began, "what you did violated hospital protocol and the chain of command. However, given the extraordinary circumstances, the positive outcome, and the documentation of your prior training and the technique you used, The committee has decided not to terminate your employment. Instead, you are being reassigned. I felt relief flood through me, but it was short-lived. She continued, you are being removed from surgical nursing. You will be reassigned to the medical surgical floor, and you will undergo additional training on following protocols and respecting physician authority. This reassignment is permanent. I felt like I had been punched. The surgical floor was my life. It was where I felt most alive, most useful. Being sent to MedSurg felt like exile. But then Margaret Holloway said something else. However, there is another option. Dr. Brennan has proposed something unusual. He has requested that you be enrolled in a physician assistant program with a specialization in surgical assistance, paid for by the hospital. Upon completion, you would return to Metropolitan General in an expanded role that would allow you to assist with complex procedures under physician supervision. This is unprecedented, but Dr. Brennan has made a compelling case that your skills and instincts should not be wasted. The choice is yours. I stared at her. This was not what I expected. Becoming a physician assistant would take 2 years of intense study. It would mean starting over in many ways, but it would also mean legitimizing what I had done, channeling my instincts and knowledge into a recognized role. I thought about my father, dying from complications during surgery. I thought about Dr. Torres and his last words to me. I thought about Thomas Garrett and his daughters. Then I thought about Helena Grant from Cedar Rapids, that girl who worked 3 jobs and dreamed of making a difference. I accepted the position. That was 3 years ago. I completed the physician assistant program and returned to Metropolitan General last year. I now work directly with Dr. Brennan in the trauma surgery department. I assist with complex cases. And yes, I have used Dr. Torres's compression tamponade technique twice more, both times successfully. Thomas Garrett sends me a card every year on the anniversary of his accident. His daughters are now 13 and 16. He is still teaching, still alive, still grateful. But here is what nobody talks about, the part that keeps me awake some nights. What if I had been wrong? What if that technique had failed and the patient had died with me alone in that room? Would I be sitting here telling you this story, or would I be defending myself in a courtroom? The truth is, I will never know. I made a choice in a moment when there were no good options, only a terrible situation and a sliver of hope. Some people still think I was reckless. Others think I am a hero. I think I am just someone who could not walk away when a heart was still beating. So now I turn this to you. What do you think? Was I right to disobey Dr. Brennan's order and stay in that operating room? Or should I have followed protocol and let nature take its course? This is not a simple question, and I genuinely want to hear your perspective. Drop your thoughts in the comments below. And if this story made you think, if it moved you in any way, please subscribe to this channel. There are so many more stories like this. Real experiences from real medical professionals who face impossible choices every day. Hit that subscribe button and turn on notifications so you do not miss the next one. And before you go, check out the video that is recommended next, where another nurse shares a secret she kept for 30 years, a secret that will change how you see hospital care forever. Thank you for listening to my story.